Hi, good afternoon. This is Professor Bowman, and I am going to start reviewing for your Pharmacology 1 final exam. I am recording this, and are there any issues about recording? Okay.
Yeah.
Okay, so let's start with administering a rectal suppository. Um, So with that topic, what I want you guys to focus on is, first of all, I want to make sure that I just changed my audio. I want to make sure that my audio is clear.
It's good. It's clear, yeah.
It's good. Okay. So with regards to administering rectal suppository, first you want to make sure you utilize water soluble lubricant, right? When you're inserting the suppository. Why? Because it is humane, right? You don't want to just insert it without a lubricant to minimize discomfort. You're going to insert it beyond the internal anal sphincter because otherwise the patient is just going to squeeze it out. You're going to ask the patient to relax the muscles while you insert. Okay. And then in terms of positioning, after insertion, you're going to ask them to lay flat, either lay flat or on one side for about 30 minutes because it aids in absorption. Again, otherwise, it will just expulse. It will just come out. And I've seen this happen many times. You return to the patient's room, the suppository is out. So it's pretty much non-administered, right? The left lateral side is often the preferred side if you're going to have them go on the side due to like the anatomical alignment with the rectum, but otherwise laying flat will also work. Now, if you have a patient with mobility restrictions, you will have to pick alternative approaches. You just have to be resourceful, okay? Any questions about that? Of course, every time you do any med administration, most especially if you're inserting anything, vaginal area, rectum area, its privacy must be provided, right? Drawing curtains, closing the door, and explaining the procedure is very beforehand, not while insertion, beforehand reduces anxiety. And it also, it really encourages cooperation on the patient. So, and then infection prevention, make sure you strict hand hygiene, wear PPEs, etc. Okay. Next is administering eye drops. When you administer eye drops, can someone tell me how to administer eye drops? Anyone? Can anyone explain? Okay, so Jasuri said, wash hands, ensure eye drop medication is at room temp, tilt the patient's head back, have them look up, gently pull down the lower eyelid to form a pocket, drop the prescribed number of drops, ask the patient to close their eye, apply gentle pressure, document, good. Okay, and then Brian, pull down skin under eye. And Ramisha said, pull down lower lid, drop into the sac. Right. So that's important, right? Ramisha, you got that one. Lower lid, drop into the sac. Middle third of the sac, of the conjunctival sac, to ensure even distribution and minimize irritation. Of course, also making sure you wear PPEs. Um, and then Jasuri said, make sure that you have gently pull the lower eyelid. That's good. And then middle third of the sac, and then applying the drops for absorption. Good. Okay. And then closing, you have the patient close eyes, which really applies the pressure to the duct, and then it helps localize the absorption of the medication. What else? Then, of course, for all medication administration, make sure you educate. Okay. Now, if you have a pediatric patient, what is a good way to ensure their participation in this eye drop administration? So a lot of pediatric patients, like toddlers, for instance, they're gonna fight you. So how do you think you're gonna get them? You are gonna get that eye drop in. Okay, good. Zachary said have baby sit. So have baby sit in parents' lap. Okay, so an assistant. Good. Okay, what else? Offer bribes, also known as distraction, right? Anuva. All right, distraction, sweet treat, maybe, yeah. So distraction. Can you allow parent to do the eye drops? Yeah, actually, yeah, as long as it's done properly. Abby, that's a good question. Yes. Yeah. Of course, you have to make sure that the parent has already done the return demonstration to you. Okay. Especially some of these kids are really scared of the white coat, right? Or scrubs. Yes, they can. In a pediatric unit, a lot of times we actually leave it for parents to do the administration, but we have to see it. Okay. Now, for elderly patients, eye drops are really hard to administer because of their vision, dexterity, right? Challenges. So you might need to help them for sure, or as utilize assistive devices like eye drop guides. I don't know if you've ever seen them. Look for an image on Google for eye drop guides. Okay, so moving on to next, allergy documentation protocols. So allergy documentation protocols, I am thinking of 3 items for allergy documentation protocols. Can someone, okay, so someone has chatted. Okay, so document all patient allergies, med, food. Okay, so document where? In a medical record, right? Jasuri, so document the medication allergy in the medical record. And then if there are new updates, update the record promptly if there's new information about allergies, okay? And then include the nature of the reaction, good. Include the date and any relevant details, good. Always update and verify, good. So every time you administer any allergies, right? Okay. Another item to note is allergy bracelets, right? Have you seen them in a clinical setting, guys? Okay, yes. So in the clinical setting, those with allergies will have allergy bracelets. So be aware of your surroundings. What's some of these patients have lots of bracelets, fall, allergies, behavioral bracelets. So keep yourself aware of what's on the patient's wrists. Okay. And then another item to remember is to notify the provider and pharmacy about contraindications of, let's say, prescription. And let's say there's a new medication given, and then you see it pops up that it's contraindicated to the previous medication that they're on, or existing medication that they're on. Notify the provider, notify the pharmacist, because sometimes, we are the last gate, right, before giving that prescription. So before the provider who prescribes and the pharmacist and us, we should be able to check those T's and I's, right? And dot the I's. We should be able to notify the provider and the pharmacist if there's any contraindications with old meds and new meds in terms of allergies. Any questions about that? Okay, this is a quiet session and it's more of a chat. Okay, so I get it. All right, so the next one is crushing enteric-coated tablets. Now I want to hear why we don't crush enteric-coated tablets, not by chat. Why do we not crush enteric-coated tabs?
It'll be released too early, and instead of going to the small intestine, it'll go to the stomach and irritate the stomach.
Okay, so perfect. Exactly what I'm looking for. But additionally, if it gets degraded in the stomach, which makes it irritating, right? What else could be the risk? Oh, somebody said it. Parto said toxicity. Exactly. Because it's not meant for the stomach, not only for gastric irritation to prevent gas, but also toxicity. Okay, so those are two major items to note: irritation and toxicity if you crush it. Okay, so it reduces efficacy, increases side effect, toxicity, because now it releases the drug into the system. Now there's a potential systemic adverse effects. Okay. So a big education part, educational patient education, is not to crush enteric-coated. Next item is effective patient education methods. So really anything that we've mentioned this throughout the semester, right? When giving medication, before you give, you educate. Before you give meds, you educate, right? Medication education at every administration. Even though, let's say, you've been working back-to-back shifts and it's the same patient, do you skip medication education? No, because it enforces to them, right, that this is what this is for. Okay, so med education at every administration, because it reinforces the key points of the purpose of the med, its proper use, so if they go home with it, right, and the potential side effects and adverse effects. Okay, now especially for new meds, you're going to emphasize to them how and when and how to take it, the dietary restrictions. Like some meds you cannot take with dairy, for instance. And then, especially, you're going to tell them these are side effects or adverse effects. These are adverse effects that can happen. And then you have to inform your provider if you experience such and such. So these are things you have to educate your patient. Don't you also need to adjust your education to the patient's learning level by assessing their understanding? Absolutely. So, Jasuri, do you wanna elaborate on that? What kind of learning levels are we talking about?
I know we had talked about like patients that cannot speak correctly or they didn't finish like high school or like their education levels. So they said avoid medical jargon, using simple and clear language.
Exactly, exactly. So you're gonna base on health literacy, right? You're going to base your education based on health literacy. So you're gonna not gonna you're if you know that they're a physician, I've taken care of patients who are physicians. Are you going to talk to them like non-medical jargon? No, right? You're going to talk to them as if you're a coworker, right? You're going to say it's an NSAID, GI upset, right? Because there's no need to talk in medical jargon. However, if they're not, then go for the non-medical jargon. Um, so good point. But there's also age specific, right? So pediatric versus adult versus older adult. Okay. And then you're going to think about culture. You're going to think about language barriers. So those are all adjustments that you pointed out that you need to be specific about when you are educating. And then when you're educating patients about med administration, patient education, right? Med administration, you need to encourage questions to clarify misunderstandings. And you're going to assess comprehension. How do you do that?
Teach back.
Read teach back. So, and then Jasuri said redemo. So teach back, right? If I show you how to give yourself insulin, you're gonna show me, right? Show me how to do. Okay. And even if it's what about verbal? Like you're gonna take this like this. Verbalize. Verbalize what I just not just a yes or no, not just a, so basically avoid passive methods. With just a yes or no, or just handing out materials, although handing out materials are also good as a supplement. But handing out materials without discussion with them is not good, right? You have to supplement it with a discussion, with a verbal explanation, and then redemo or reverbalize. Okay. So we talked about teach back, and then there's also visual aids that you can utilize, and then learning preferences. You can ask them about their learning preferences, some like hands-on, as even as nurses, right? As nursing students, how do you like to be taught? Do you like, some of you guys love skills, right? Because it's hands-on. Once you become once you are a new grad, I personally like hands-on. I don't like it. I did not like, sorry about that. I did not like didactic as much when there was lecture, although I mean, it was very beneficial. But once I started being on the floor and taking care of patients and touching, that was when I learned the most. Okay. So, and then the common mistakes really to avoid in this case would be overloading information, um, you know, too much detail, making sure you just focus on critical points and now also assuming knowledge, right? So sometimes, now you'll see this a lot. Sometimes you assume we will assume that they understand, because they may not always admit that they don't, that they know, that they don't know. So make sure you still go over it anyway. Go over the med education. Okay. All right, the next one is effective FDA approval requirement for pharmaceuticals. Do all pharmaceutical drugs need to be FDA approved? That's as a yes, right? All drugs, prescription drugs, need to be FDA approved. Okay, it goes through what phases? It goes through blank trials. What's blank trials? Fill in the word. Fill in the blank. Clinical trials.
Clinical.
Right, clinical trials. So there's actually, before the clinical trials, there's a preclinical research, and then it goes through phase 1, 2, and 3, and then new drug. Okay, so if someone says, here's a drug, try it, but it didn't go through FDA, that's not an approved drug. Okay. Now there are exceptions. Okay. There could be experimental drugs for patients with serious conditions. Of course, for compassionate use. And then let me ask you this, are over-the-counter drugs FDA approved? Zachary, you said no. Is that the answer for that? So it actually, yes, Gabby, it requires FDA approval. However, it goes through a different process, not as stringent as a prescription drug. Okay, but it still does go through FDA. All right, moving on to handling expired meds. What do you think? Give or not to give?
Do not give.
Do not give, right? If it expired today, do give or not give?
Don't give.
Not give. So what do you do with it? Trash, biohazard, incinerator. Take it back to whom, Abby? Properly disposed to whom?
Professor, in the hospital, I remember a nurse told you that you put the medications in the red little like hazard.
No,
bin.
those are, no, so if it's expired, the hazardous materials would be if it's been used, it's incinerated, it usually goes into, if it's been used, you put it on the blue bin because it needs to be incinerated. Okay. A red bin are for biohazards. So blood, feces, all that stuff. Okay. If it has not been used and it's expired, who do you give it to? You don't discard it. You return it to the pharmacy. Good, Melissa, Abby. You have to return it. They have to account that you did not give it to the patient. Otherwise, it's like, where did it go? Did Abby take it home? Did Melissa take it home? Did they give it to the patient? Okay, it doesn't just get discarded. It returns to the pharmacy, because they will then properly dispose it and then replace it with the appropriate medication, okay? So with that in mind, we're talking about handling expired meds. It is important, but that before you give your med, I've seen it, always check expiration, because we're not perfect. Pharmacists are not perfect. Sometimes they're expired, right? So you always check for expiration also. And very good. Melissa said, and verify the actual med before pulling it from the bin. Of course, right? That's first check, right?
That actually happened to me in clinicals this past week, where I pulled all the meds for the patient that I was doing the med pass for. And when we got to the room,
Wrong
the
patient.
not the wrong patient, it came from the right bin. But when we went to scan their wristband and to scan it into Pyxis, what was placed in the bin by the pharmacy was actually not the right not the right medication.
Ah, okay, see?
So
And
we
then you
had to
also
call the
sometimes
pharmacy
find
and
the wrong patient on the wrong bin. So that also happens. So you're thinking it's all from the same for the patient. So it's good catch, right? So that's why our lovely computers also does it for us, right? All right. Any questions about that? All right. So IV drug compatibility and administration rate. Oh, I'm sorry. Identifying prior to administration. Identification prior to med administration. What do we have to verify before we give meds?
Name and date of birth.
So verify two patient identifiers, right? And it's usually name and date of birth, right? Against the med record and wristband. So you're gonna not rely on room number or what the patient looks like. So if the patient's alert, you're gonna ask state name, date of birth. Okay. Now, special circumstances, non-responsive patients, how do you do that? With two patient identifiers. You're gonna use check the wristband, cross-check against the MAR. Good, Anuva. Good. Patient picture in chart if available. That would be another way, but always check the wristband, right? What about pediatric patients? Family member, good. Pediatric patients, family member, caregivers. But of course, you still will verify wristbands, right? What about similar name patients?
middle name.
So their date of birth hopefully is different, right? They might have the same name, but they should have a different, right? Then you would have to bust out that medical record number, right, Armina? To prevent confusion. Okay. IV drug compatibility and administration rate. Every time you infuse IV, you need to be very careful with compatibility. So you need to verify compatibility with IV fluids. So you always need to check the drug if it's compatible with the IV fluid that's being run. Okay. So let's say I'm going to infuse amoxicillin IV piggyback on a D5 water. You want to make sure it's compatible. If it's not, what can happen? And I'm infusing it piggyback.
It can cause an adverse reaction.
Right, to the patient, precipitation, good. Parto said precipitation, right? Adverse reactions. It can increase or reduce the drug efficacy, right? It can cause phlebitis on the IV site. It can screw up your IV line, infiltration, good, right? Speaking of which, I think I'm going to talk about it later, but I want to point out potassium chloride. So make sure, so potassium chloride IV is one of these drugs that are it's given a lot in a critical settings. Potassium chloride must be diluted when given. Never push potassium by itself, always with chloride, right? Drip, never push. Good. Both Gabby and Melissa said it correctly, right? Because why? What is the side effect of non-diluted push potassium chloride? Myocardial infarction, burning on the veins, can cause death. It's cardiac, right? Okay. And what is the max rate on a peripheral IV line when you're infusing? 10 MEq per hour. So this is for a peripheral IV. 10 MEq per hour is the max rate for potassium chloride. Now, once you start working in a critical setting, critical ICU setting, or ICU setting, I should say, that's redundant, you can actually infuse it faster, but only if you have a central line. But for now, peripheral IV, it's 10 MEq per hour. Okay. Managing opioid withdrawals. Managing opioid withdrawals is actually quite difficult, especially if you are not used to taking care of patients with such. Remember just to recognize symptoms, early symptoms, later symptoms. Typically, patients in the first half a day of like 6 to 12 hours of like short-acting opioids, they would be restless, anxious, sweaty. And then later on, like the third day, like 72 hours, they would have nausea, vomiting, diarrhea, abdominal cramping. Typically, symptoms are like not life-threatening, but to them, they can have significant distress. Jasuri said, I had a patient who was going through alcohol withdrawal and knew a lot about meds and would request for fluids via IV. Okay, yeah. So they already know what they were doing, right? Okay. And you're not required to know which med management to intervene for opioid withdrawals. But there's a bunch, like methadone, clonidine, loperidine, there's a bunch of them. And then of course, antiemetics, because a lot of them are having nausea, vomiting, but you're not required to know that for this class. But just remember to recognize symptoms of opioid withdrawal. So especially, you'll see this especially in the ED, right? Emergency department. They walk in, they're having these symptoms. No, you're going to assess them for opioid withdrawals. Med effectiveness and patient feedback. How would you know if a patient, if the patient is actually, if the medication is effective to a patient? It's not a trick question. How do you know if the patient is receiving, is the medication is receiving, if the medication is effective? You ask them. If it's pain, good. Verbalization when asked. And let's say if it's pain relief, they say, okay, my scale was 8, now it's 2, right? Blood pressure is reduced, good. So you're measuring therapeutic benefit, right? Blood sugar high, now low. Symptom reduction. That is how you check effectiveness. And reassess. You're going to ask for patient feedback because you ask. That's what Gabby said. Okay. So you're going to avoid, though, you're going to limit satisfaction of, you're going to limit subjective items, subjective statements, because you also want to do objective assessments, right? So it's good to ask, but also objective, right? So they say pain, good, but is their heart rate lower? But because with pain levels, it's usually high, their heart rate's high. Is their heart rate lower now or normal? Then yes, their pain level is lower. Then their pain level must be lower because their heart rate has gone down. Patient education and readiness to learn. I guess there's not much to say about this, but you don't educate a patient when they're not ready to learn, right? First, you have to make sure that they are in a, not sleeping. They are not anxious or fearful. They're in pain. That's a big thing. Like they're in pain, forget it. You're educating the patient about meds or anything about their discharge. They're in pain. They're not going to learn anything. How are they, if they're sleepy or about to go to sleep, are they sedated? Physical state, they're not going to learn anything. Is the patient mentally alert and able to comprehend the information? So make sure readiness to learn is the #1 priority before you educate a patient, okay? Whether it's about discharge instructions or whether it's med administration or whatever. Patient refusal of meds. What happens when a patient refuses? What do you do?
You don't give it to them and you notify the doctor?
Good, right? You hold the dose. You hold the dose and you tell the physician or the PA or the NP, right? Why is that? What is the ethics? What is the underlying ethics there?
Patient autonomy.
Patient autonomy, good, right? They have the right to refuse treatment, including meds. I mean, you're probably wondering, why are you here? Right? Why are you in the hospital? But that's under your breath, of course, right? But they have the right to refuse. The doctor can talk to them about adjusting. Like maybe it's cultural, right? Maybe there's a reason why they don't want to take it. We need to get to the bottom of it. And then make sure you document the refusal, right? Because you will say not given on the medical administration record, patient declined. So it's not just a not give, because otherwise it looks like you just didn't give it because you forgot or whatever. Pharmacogenetics. Can somebody define pharmacogenetics? Study of how patient's genome affects his or her response to meds. Good. So how we metabolize, how our genetics dictates our ability to metabolize or respond to drugs. Okay, good. Brianna also noted a few types of definition. Good. Those are all correct. Brianna also mentioned what I wanted to say next. Helps individualize drug treatment regimens. Yes. Study of genetic factors influence on drugs response, drug reactions. Now, an example of this, a classic example is Coumadin, warfarin. That's one of the ones that there's a variant in our gene that alters the patient's ability to metabolize Coumadin, right? So now the patient has to have dose adjustments so that they don't bleed or clot too much. What is the challenge though in pharmacogenetics? What's the problem with pharmacogenetics that we've talked to you guys about? Affordability. It's different for everyone. What do you mean by that? Privacy. Okay. Onuva, I think privacy has been somewhat fixed now. There's been a bill that you should not be able to be denied healthcare insurance. However, part of what you're saying is true though, because your life insurance, you might get denied life insurance because of a variant in your gene. Okay. So part of what you're saying is true. It's different, but affordability, it's expensive. So access and equity to pharmacogenetics, it's limited access because of disparities in care, right? Only for the ones who can afford it, right? Lack of knowledge as well and expenses. I won't say that out loud. Okay. Moving on to pharmacotherapy in older adults. So what are issues or what things to note of? What considerations should we think about when we are dealing with older adults and pharmacotherapy? Polypharmacy. Good. What else? Experience altered pharmacokinetics due to changes in metabolism. Right. So kidneys are slower, are decreased kidney function, decreased liver function, right? Okay, good. Also altered cardiac function a little bit. Slower absorption. They have decreased, I don't want to say I'm not there yet. Reduced gastric acid production. And then they have slower gastric emptying. So it delays the onset of drug. Okay. So with decreased liver function, they have increased risk of toxicity. And then remember the albumin effect. They have reduced protein levels or albumin levels in the body. So now there's free drug roaming around. So now there's more chance of toxicity. Okay. So what do we have to do as providers? We have to be more cautious. Not so much us, but we have to take note of those adjustments. Monitoring for renal function, liver function, polypharmacy risks. All right, I think I've already nailed that. Preparation areas for meds. Where do you prepare meds? Patient room. In the med room. Thank you, Zachary. Thank you, Onuva. So it has to be a specific place for a med prep area. It has to be clean. Pharmacy area, designated counters. What's wrong with the patient's bedside? Not clean, probably. Not aseptic, not sterile, maybe, yeah. Cluttered, there's food, there's personal items. So when we're talking about preparing, I'm talking about preparing medications. I'm talking about like diluting stuff, okay? Or putting one IV fluid into a bag. Okay, and risk of losing it, yeah. That too. It's a mess, right? You've seen patient rooms. By the way, patient room, and I remember being in nursing school about this. I got yelled at by an ICU distraction of patient. Yeah, but by my clinical instructor, because I walked out of my patient room and I didn't pick up something from the floor. She said, "You have to clean up your patient's room." And there was like piece of paper or a wrapper on the floor. Make sure you look at your surroundings, clean up your patient's room. I know we're not housekeeping, but we are partially housekeeping when we're in a patient's room. So clean up your patient's room, okay? So also when you're in a patient's room, is it have adequate lighting? Not necessarily. You don't have labels unless you bring your own labels, right? And most importantly, it's not a proper place for mixing, okay? Proper injection sites. All right. So let's start with intradermal. Where do you inject intradermally? Intradermally. Intradermis, but what part of the body? What sites? Forearm, inner forearm. Also upper back. They do allergy tests there. Okay. What's an example of, I said allergy test, so I already gave you upper back. Also on the arm. TB testing. What's a tuberculin test, right? What's another term for TB test? Mantu, another term. PPD, what does PPD stand for? Okay, you can Google it, but it's purified protein derivative. So all those can come up on your test, right? Mantu, TB, PPD, they're all synonymous. And then there's the allergy test also, are all given intradermally. And you were already tested about the needle size. Well, it didn't come up on your test, but you were supposed to learn it. So you should know the needle, the angle, okay? Now, but what about IM? What are the sites? Where can you inject? Okay, deltoid. Deltoids are good for small volumes only. It's good for vaccines. Glutes. Oh, so good. Yes. deltoid. For babies, vastus literalis. So it's like on the, you know where your vastus literalis is, the outer thigh. That is an IM shot for them. No, no, I'm just saying that no, you won't need to know syringes but you need to know it for the rest of your life, right? Nursing career, right? Yes. All right. Sub-Q. What sites would you give sub-Q? Thigh, abdomen. Okay. All right. What med? I know we didn't talk a lot about meds, but which one do we know about given sub-Q? Insulin, good. Heparin, okay. And then we talked briefly about a particular IM technique, which is the Z-track method. You guys remember that? Did your instructors talk to you about Z-track? Okay, so Amina, can you tell me about Z-track method, or Melissa, can somebody talk about Z-track method? What is the purpose of Z-track method?
It minimizes the skin irritation.
Yeah, because typically Z-track method, it's for meds that are really really thick medication. So it's given via Z-track, so it reduces local irritation. So it doesn't get on the sub-Q. That's why you do the Z-track part. Okay, so the technique is you pull the skin, you pull the sub-Q tissue before you inject. So you then don't get into the sub-Q tissue. So, and then you're gonna inject at 90 degrees. You're gonna wait for like 10 seconds, and then you're gonna withdraw the needle. Iron supplements are given sub-Q, and another med, Haldol, I think. Haldol, yeah. Purpose of IVLR, lactated ringers. I think we've talked a lot about this. What is the purpose of lactated ringers? First of all, lactated ringers, is this? So, Gabby, it's not normal saline, right? Normal saline is normal saline. It's normal saline plus what? Melissa said water and electrolytes. Got fluid and electrolytes. That's the point of LR. It's isotonic. And it's good for which population of people? What kind of sickness do they have? Dehydration, surgery, trauma to restore fluid balance and maintain proper electrolytes. Yes. Okay, good. How do you safely no oral intake? Right. But no oral intake can be some, I could just give you NS, Parto. Maybe your electrolytes are good, and I don't care about your electrolytes. Maybe you're not throwing up. Then I can just give you NS. So someone who have been dehydrated and have had electrolyte wasting of electrolytes. So not necessarily no oral intake, okay? Safe administration of topical meds. So anytime you apply topical meds, what do you have to wear?
Gloves.
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 Gloves. You don't use your fingers, right? Why? Aside from the obvious. I mean, actually, tell me the obvious.
You're drugging yourself along
You're
with
drugging
the patient.
yourself. Protect your skin. Protect yourself because it's going to absorb to you. You're protecting yourself from exposure. irritation, or if you're allergic to it, then you're screwed. And then what else? Then you're contaminating the medication and the site. That's just gross, right? Okay. And then if you are actually giving the medication, the topical meds, what else can you utilize?
Cotton swab.
Cotton swab, what else? Tongue
Tongue gauge.
depressor, good. All right, those items, right? Okay. School med policy for children. If you are a school nurse, what do you have to be cautious of? Giving a drug to the student without a written consent from a parent, and if it's a prescription, without a healthcare provider's authorization. Okay. You'll learn more about this when you do public health nursing, when you do your public health rotation. Now let's say a student walks in to your clinic in the school, or you're walking around nutrition, right? And then you see a student with a pill about to bust out something, a school, fifth grader, a pill put in their mouth. What are you gonna do? Right. You want to see what that, you're going to call their parent immediately because it needs to be labeled with a child's name. Take it away. Yeah. Needs to, yeah. Come with me. Take the child with you. What's going on? Because every prescription or everything has to be labeled with a child's name, med name, dose, all that stuff. Because you need to know what's going on with the child, right? So contact the parent, and then don't give it until it has to be properly labeled. Okay. All right. Protect your license. Spiritual beliefs in medical treatment. So, if you haven't had an experience already, you will encounter not only cultural differences in the clinical setting, but spiritual not just spiritual encounters, but not ghosts, but they will have spiritual beliefs that may influence their healthcare decisions. Okay, so the most important thing is to accept their spirituality, right? Because their perceptions of their illness is maybe different from ours, and medical interventions are different from ours. So it's important that you incorporate those beliefs into your care plan. I know, care plan, right? And then involving the provider, involving the doctor. Like, they don't want to do this because the parents are, let's say because they believe in this and this, because there is a way. I'm going to have to tell you most of you guys know, I work in the neonatal ICU, and we have very devout Muslim mom and dad who the mom would refuse to do skin to skin. I don't know if you kangaroo care. So she would hold the baby right next to the twins, next to her chest, next to her breast, right? To increase breast milk production, to normalize the temperature of the baby, etc. But she refuses to do so. Okay. It's a quality measure for us, etc. But she refused it. And the babies were there for like 120 days in the NICU. But what we found out after like 30 some days is that what she did not like is that there were men in the area. She did not want anyone in the pods, even if it's a doctor, respiratory therapist, male in the neighboring area. So what we've decided is that if the mom is there, no men in that neighboring area. And we allowed modified skin to skin, even if she just touches the baby's face. That's enough for us. Because spiritually, culturally, we allowed that for them. Okay. Sublingual med administration. Going back to the spirituality. Spirituality is included under cultural competence, right? Make sure you, it's one of the things below, one of the second to the last one noted on the study guide, understanding cultural competence, right? Be aware of your patient's culture, okay? Sublingual med administration. Drugs given via sublingual, under the tongue or buccal, between the cheek and gum, okay, fully absorbed. Therefore, no food or fluid should be taken while the med is in place, as it interferes with absorption. Good. So you got that one. It's tongue allowed to dissolve. Don't chew. Don't swallow. Right. Does sublingual bypass the first pass effect? Yes. Good. Okay. And you noted avoid eating, drinking. It has a rapid onset. Okay, it's quick action. A very good example is nitroglycerin sublingual. It's for angina, right? We talked about it in pathophysiology. Okay, also anxiolytics. Okay, all right. Okay. Transdermal patches. Transdermal patches, nitroglycerin is an example too. It's good for providing consistent blood levels for the patient, okay? It really avoids the highs and lows. What's the word? The peaks and the troughs of the level of the drug. So it's consistent throughout the patient's system. It's good for pain. It's good for nicotine withdrawal. You've seen transdermal patches for nicotine withdrawal. Nicotine withdrawals, right? Hormones too. What you don't want to do is you teach the patient, don't reapply in the same spot over and over again, because that will irritate the skin that we're reapplying to. So rotate the application site, okay? Types of crystalloid IV solutions. What are they? There's 3, right? What are they? So Jasuri said, okay, there's 3 kinds. There's 3 types of crystallite IV solutions. So you've given me examples, but what kinds of crystallite IV solutions? There's isotonic, good, hypertonic, and isotonic. Isotonic, hypertonic, hypotonic. So isotonic would be your same, no fluid shifts, right? Similar to blood, plasma. So normal saline, NS, lactated ringing. Okay. Hypertonic, an example would be what? It's good for intracellular dehydration. So it's good for reducing intracranial pressure in brain injuries. So mannitol is a hypertonic solution, but what other ones? Examples? Anything with dextrose, D10, D12, anything like that. Okay. Sodium chloride, 5%. Okay. Those are all hypertonic. Then hypotonic will dehydrate. Okay. So what would that be? Examples would be half normalized saline, right? Cultural competence, I've already kind of discussed that, making sure you build the trust of the patient, right? You know, the patients, ask them, like, can you tell me more, right? If you don't know, look it up or ask them. Use of spacers with inhalers. Why do we use, so inhalers meaning meter dose inhalers, like for asthma, albuterol. What's the purpose of spacers? Devices used to enhance the delivery of meds from the meter dose inhalers. It's effective of inhaler use by allowing meds to remain in the chamber longer, giving patient more time to inhale it deeply, properly. Yeah, very good. So it's actually beneficial for those who don't know how to use an inhaler, bottom line, right? Because it gives them allows them for that chamber to keep that medication in there, lets them inhale it longer. Okay. Kids are the primary users of spacers, pediatric patients. Okay. And then lastly, water flush in G-tube med administration. Why do we use a water flush after each med administration?
To make sure that all the medication is kind of like pushed into the stomach.
Good. Yeah. So water helps push the med through the tube into the stomach. So making sure that every dose is delivered to the patient. And then also provides it, so it prevents the residual med to adhere to the tube, right? Because it would reduce the effectiveness. Because if it just stuck on the tube, then you're not giving the entire dose, right? And then secondly, it maintains the tube patency. What if you gave a medication that's really thick and then you didn't flush it? Then it's just gonna go clog it. It's like a bad toilet. And then you're gonna give the next medication. It's just gonna get stuck there. You're gonna have an overflow. Yep, exactly. Crazy, right? And I hope that your instructors have shown you how to you will find it in skills. You will find out how to give tube meds, G-tube or NG-tube med administration in skills. Do you guys have any questions? I went over a little over an hour. Do you have any questions? Okay, all right. I've covered everything, I promise. Okay, I won't see you next week. I'm missing next week's class or exam, but I'll see you guys next semester. And I will be saving this on the OneDrive, and I will send it to all of you guys. Did you guys get the Patho link? Okay, I will do the same for this.
Thank you.
All right, have a good night, everyone.
Professor,
Yes.
can you please send the patho link because I don't have access to it.
No, I sent it to all TBSN. Did
Hmm.
I sent the link to everyone. Did you check your email?
Yes. Let me see.
Melissa, I had tried to send it to you in the Discord. Just let me know if it opens.
Okay, thank you. I'll
No
figure it
problem.
out. Thank you, Professor. Thank you,
Okay.
Alina. Okay.
All right.